Just a quick disclosure to share in conjunction with this podcast. Each of us are speaking to our personal experiences and do not consider ourselves experts and cannot offer medical, therapy, financial, or legal advice. We represent a wide range of experience on the autism spectrum and will always honor each perspective that is brought to our discussions. Our experiences, opinions, and perspectives are all unique and different and will be celebrated. Thank you so much for listening and connecting with us. Thank you. Hello, welcome to Navigating Adult Autism. We are just a bunch of moms with a lot of experience, a bunch of opinions, and a lot of perspectives. My name is Mary. I'm here tonight with our moms, Cynthia, Elizabeth, Tara, and Kara. We are missing Heather and Dawn. We miss you. We are here tonight to talk about medication and autism, and we are joined by 3 doctors from the Arc of the Ozarks Autism and Neurodevelopmental Center, a place of hope, which we are thrilled to have them. So before we get started talking about medication, I'm going to have all the doctors introduce themselves, and we'll get started. So we'll start with Dr. John.
Hey, welcome. Yeah, thank you. Excited to be here. Dr. Kyle John. I'm a child and adolescent psychiatrist. Been with the ARC for a year. Did my medical training at the University of Missouri in Columbia, and then up to the Mayo Clinic for my psychiatry residencies in adult and child psychiatry. Been doing this for almost 30 years, so that's kind of exciting, wow. And it's a topic that's near and dear to my heart. And I'm blessed to have a great partner, and I'll let him take it away.
Thank you, Kyle. I'm Dr. Tan. Did my medical school at Southwestern University and did my residency and fellowship at the University of South Dakota. I have a particular interest in pharmacogenomics and interventional psychiatry.
Wow. Okay, Dr. Lindsey.
I'm Dr. Lindsey Reichert. I'm the Director of Diagnostics and Counseling here at the ARC. I also am a clinical psychologist.
Great. So one of the first questions when the moms were meeting and we were talking about medication and autism, which is very scary sometimes and conflicting, does medication help when someone has an autism diagnosis?
Well, I'll start, and then I'm sure the others will chime in. So medication, there's no medication for autism.
Okay.
As everybody knows, there's not like you have strep throat and you take some penicillin and it kills the bacteria, and voila, your strep throat is gone. As a neurodevelopmental disorder, autism has many shapes and sizes and flavors, and often there are symptoms of autism and comorbidities that can become problematic. I'll just give you some examples. So maybe somebody with autism has some anger issues, or they have some repetitive behaviors where they harm themselves, they bang their head or punch the wall, or even rock to the point that they are causing some trauma to themselves or furniture or whatever. There can be comorbidities like anxiety or ADHD. Those things there may be an opportunity there to use medication to decrease those particular symptoms and improve the overall experience for the patient and family. There are some medications that are FDA approved specifically for autism. For example, the aggression associated with autism sometimes. And we also often use medications off-label, meaning that they're not necessarily FDA approved. And if they're not, that's most often because the research just hasn't been completed. That doesn't mean the medication is not safe and effective, and it also doesn't mean it's not standard of care. It may still be the standard of care for a particular issue, even though it's not FDA approved. And that's true for many things that we do in child psychiatry. Mm-hmm. So we do use medications, I would say conservatively, carefully, when we're treating folks with a neurodevelopmental disorder like autism, because they often are a little bit more sensitive to medications. And I know we'll get into it in this hour talking about pharmacogenomics. I'm going to let Dr. Tan, our expert, talk about that. But that can be a guide to the medications that are used in autism. thankfully, there's some research. There's more and more research about medication use in autism. And so there's always the opportunity for new things to come to market, or old medicines that may now be kind of come into favor for use for such things as anxiety or ADHD or whatever. So I think medication plays a key role for some folks. There are lots of folks out there on the autism spectrum or with other neurodevelopmental disorders that will never take a medicine in their life, and that's awesome. They're my favorite patients. I don't have to use medication, and that's terrific. They use other therapies. It could be some counseling with Dr. Reichert, or it could be speech or occupational therapy or physical therapy or ABA, applied behavior analysis, to work on a particular problematic behavior, and medications, may not be necessary. So that's great if that's your child, but sometimes these kids and adults are going to need medications, and then I think we, at the ARC, we're blessed to have Dr. Tan and our partner, Dr. Dobard, who works with our adult patients, and 4 nurse practitioners that all work with our clients and their families to prescribe carefully and conservatively, and to help them have a more positive experience.
So are there commonly prescribed medications for people diagnosed with autism? Are you comfortable in saying what the common ones are, or does it vary?
Raymond, why don't you take that one?
So let's say if one is displaying behaviors that are very aggressive, or a lot of aggression, head banging, biting, often with the FDA, and has an FDA label, maybe like risperidol, Abilify, they are on label. But it doesn't mean that you can't use like other atypical antipsychotic mood stabilizers. It's just those are the 2 that have the FDA indication for that.
And that's a really important part for everybody listening. It's an important point, rather, is that the group that Dr. Tan is talking about, the atypical antipsychotics, first invented to treat schizophrenia and later became FDA approved for bipolar disorder. The Abilify and the Risperidol have FDA approval for treatment in autism for aggression, but that's not to say that others in that group aren't used. It's a good example of what I mentioned earlier about off-label. So if I used Rexulti or Seroquel for that same reason, I'm not being a bad doctor because I didn't use one of the FDA-approved medicines. There was likely a clinical reason why I thought those would be a better medication. So that group, I would say, is one of the most common groups of medications. I think another I'll let Raymond talk about are because we see so much comorbidity with anxiety and ADHD. Do you want to talk a little bit about that?
Well, there will be times that we consider to use SSRIs, sometimes SNRIs. But one thing that's that I have heard recently is that some of the autistic spectrum kiddos, compared to the other kiddos in the community, may not tolerate it that well. So what you would think would work in the kids in the community, sometimes they'll say maybe mirtazapine would work very well instead, and even Buspar had over the SSRIs. But in the general community, they would say if you have to be on a medication for anxiety, then SSRIs are often considered first before any other class of the antidepressants.
Yeah, so medicines like Celexa and Lexapro, Zoloft, Prozac, probably people have heard of those, and those are used most often first line, but some of the most recent research that Dr. Tan and some of our staff were exposed to at a recent conference would suggest that mirtazapine or Remeron or Buspirone or Buspar may be better choices for those on the spectrum. So that's what I was alluding to, that there's new research out there all the time that helps us kind of hone our craft, if you will, what we're doing to help our patients. First, do no harm. So pick a medicine that you think will be successful, and I'm going to at some point want Dr. Tan to talk about pharmacogenomics, because it's a technology that we've been using for 10 to 12 years now that really helps us sometimes narrow down the appropriate medicines to be considered.
Yeah, we can talk about that now if you'd want to jump into it. That's
sure.
Fine.
Yeah, Raymond,
Wow, that's interesting.
So one thing that's important is to know, like, there are some individuals that when they take medication, that they can tolerate it very well, but others it would cause severe side effects or drug reactions, and others, even though they can tolerate it, it just lacks efficacy. So what does that mean? It's being able to identify and sequence their DNA and to see if there is a drug-gene association that can lead to a better outcome, better tolerability, the way they can metabolize it. And that really matters because one thing about autistic spectrum is they are sensitive to medications, but also that they may not be able to verbalize very adequately what they are experiencing.
Right.
So in some of those cases, it's very important. Can you start with a medication with where the probability is that it will most likely work and very well tolerated? Though the effects of whether a med will work or not are complex. It's not just pharmacogenomics or evidence-based. It also can be things about their age, things that their diet, different medical conditions. So it's it's just using pharmacogenomics is just one part of the piece that can help lessen medication failures and improve treatment outcomes.
Is that the blood test that you take? Because I think one of our
Actually, no.
It's not.
Or is it the gene site?
It is. GeneSight is an example of a pharmacogenomic test that we use. It's one of our favorites for a couple of reasons. One, it's one of the best tests available, and two, the GeneSight company covers Medicaid, and not all companies do that. We treat a lot of families who have Medicaid, and they couldn't afford the test otherwise. And so it was a great pairing of an excellent test by a company that really is a good partner, if you will, in terms of helping families have access to the test. So the GeneSight test is just one example, but it's a cheek swab test. So it's a Q-tip inside your cheek, not the back of your throat, like, when you have a sore throat or whatever, you gagged you. This test is so easy to do. It's really a home kit, although we do it in the office. It could be sent to somebody's home. I once had a child that was so sensitive about kind of oral things. I said, just wait till they go to bed tonight. And then when they're sleeping, take that Q-tip and 10 swabs on one side and the second one, 10 swabs on the other. And we put it in the envelope and FedEx it off and get our results. So it's a very tolerable test.
And one thing I want to emphasize that the GeneSight test, pharmacogenomic test, was developed by Mayo Clinic and also Children's Cincinnati Hospital.
Wow.
Yeah, so it's got a lot of good science behind it. But there are other tests out there, and this is, while we feel very strongly that this is a good fit for us, there are other companies that have these kinds of tests. Dr. Tan and I believe that this is best practice and that it's the future of medicine. There are a lot of people that say, well, let's wait till you've failed 2 or 3 drugs before doing this. And I'm like, well, who wants that?
Right.
Why would you want to fail 2 or 3 drugs?
Right.
So I tell my families that I'm testing that sometimes I've heard the GeneSight company refer to the test as the right drug test. I call it the not the wrong drug test, because really what it tells me is all the medicines that I might consider for a particular issue, which ones are more likely to work well for this particular client. So I don't do that trial and error. Let's try this one. Oh, it didn't work, or they didn't tolerate. Let's try this one. Oh, I didn't. And then finally the third. I mean, that's just decreases, faith in the provider. It's frustrating for the patient and the family. And so it doesn't guarantee using pharmacogenomics that we're going to get it right the first time, but it certainly improves our chances. And I want to reiterate what Dr. Tan said is it's just one of the pieces of the puzzle. And I know we often use a puzzle piece for autism. So it's just one of the pieces of the puzzle that we use when considering what medication may be best for a patient. So I don't want anybody out there to hear this podcast and think, well, if I have a test like that, then the doctors are going to know exactly what my kid's going to work. It's not that simple. Right. It really is one more thing to consider, but an important one.
Yeah, very helpful.
And you did that with our son, too. You did it. You performed it for him. So.
And it worked.
Yeah, it did work.
Yeah.
It was good.
It was helpful. You didn't have
Very helpful.
Oh, that's awesome, Elizabeth.
Yeah, and so my experience was kind of the same. It was, the parent, we're very big on the parent experience here, as you kind of gathered. But we had a son with Dr. Tan, and we were there right before the gene site test started, and we tried a patch, and, he didn't eat, went down to half a graham cracker a day, and went in, and Dr. Tan said, well, I just brought this here, let's try it. And when we did that, the medication he was on was all red. It was lit up as this was not. So at that moment, I was like, well, I'm a believer, because we'd already done it. So what is that, a blind test?
Yeah, it's like the proof. The proof was in the pudding there.
Because we'd already tried the medication. And we knew that it didn't work.
Interesting.
But then we backed it up.
We did the same thing. I've had all 3 of my kids done, and they all are exactly the same green drugs. But we did the same thing with our son, and Dr. Tan did it for our son, and found out that he was taking a red drug or something. Switched him to Buspirone, and it definitely changed the course.
And for folks that have never seen particularly the result page for a gene site test, which is the one we use, it has columns of meds, red, green, and yellow. And it's important to know that green doesn't mean good and yellow okay and red bad. It really means green will be metabolized normally by that particular patient. You don't need to make any adjustments. You don't need to go higher or lower on the dose. Typically, for a drug to move from the green to the yellow or to the red, there is an increasing adjustments that need to be made. So maybe the dose needs to be a little bit lower or a lot lower if it's in the red zone. So Dr. Tan and I and our nurse practitioners, we prescribe meds in the red zone all the time. But we do it with that knowledge in hand. So I think this is the best drug for your child or for your adult child. And I know it's in the red zone, but I'm going to lower the dose to a quarter of what I would normally prescribe because your child metabolizes or breaks down this medicine very slowly. So just so you know, it's important for folks to realize when they get a hold of the results that it's not just as simple as green means good. Anything in the green is going to work first shot. And but it's really helpful, and and Dr. Tan is the expert, but there are a lot of medications now that have FDA indications on their product label. So if you read the product label on some of these medications, it'll say the FDA has recognized this concern from a pharmacogenomic perspective, and so it's pretty hard to ignore if we're held accountable as prescribers to know that information. How do we know it if we don't do the test? So I have this fantasy that, when babies are born, you guys all of babies have this experience. They prick their heel for those inborn errors of metabolism, which can be life-threatening in the first week. I say you swab their cheek at the same time, and you get that information, and you can use it throughout their lifetime. It may take us a while to get there, but I hope someday we're there, because why wouldn't you want to know that about? Right. There's a lot of other medications outside of psychiatry. That's a whole nother podcast. Right. But there's a lot of medications that get metabolized in the liver where these enzymes are. And if we know whether you have the normal amount or a high or a low amount of those enzymes, then we can predict how much we may need to adjust the dose. So we're believers. We've seen those cases. We've had those patients that we've tried 3 or 4 medications before one of these tests was available. Then we tested them, and we're like, oh, no wonder. I never got the dose high enough. No wonder they never responded, or no wonder they don't tolerate that medicine, whatever. So it's been a significant enhancement in our practice over the last few years.
I think it's also important to point out as well is I have a lot of parents that come to me with young kiddos and are like, I'm not ready for medication yet, Lindsey, but I'm afraid if I let this go on too long, they're going to get kicked out of school or, and so what I always do is it's a great segue into, hey, Dr. Kyle John, my buddy over here, he is more than willing to look at your kid, check out. It's just a cheek swab, nothing else. And then we have it on file. So instead of being crisis mode here, we're going to be preventative. Right. So that way you have it in case you need it. And so, if those parents are kind of teetering on, I don't really want to start medication yet, it's always a great segue into saying, hey, we at least have something on file to know when it is time, we're prepared.
Yeah. And important to point out that, we don't necessarily want to lead with medications, right? We want to lead with therapies. But there are times where it's not safe.
They're in crisis mode already, maybe.
They're in crisis mode already and at risk. They've been kicked out of 4 daycares and no summer school because of their, and there are consequences of not treating. So, but I would much rather have a child who's enrolled in occupational therapy to work on some sensory issues than just throw a medication at them and hope that it makes a difference. And talk therapy or group therapy for kids that can utilize those therapies, hugely important. But there are times where the medicine really should be prescribed, and a few times where you really do need to lead with the medication.
Sure. So that's normal procedure then when you think a child or an adult needs medication?
I will do it, and I'll tell you why. Because some have asked me, is pharmacogenomics evidence-based medicine? I said, of course. And they'll say, how do you prove that? Because it already is not only in pharmacogenomic guidelines, but they rank the level of evidence on it. They will be at the level 1 or 2.
Right.
And when they are at that level, they can affect your dosing or adjusting or switching. So it is very important. And it can be even considered value-based, because there are health utilization studies that say less trips to the ER, less stays at the hospital, longer stays at work, and not missing as much, less reduction in polypharmacy. And it goes further in that. The other areas outside of psychiatry use it a lot. And who are they? Oncology, like at St. Jude's. And they do very complex type of pharmacogenomics and genomic profiling. They go at the level of chemotherapeutics, but they also go at the immuno and targeted therapy, and that sometimes it's a lifesaver like that, because it has a specific genetic determinant which that molecule has specificity for, but it really has that personalized design for it.
Wow.
Yes.
That's interesting.
And not only onco, there's a primary care version, because it could be that I'm not depressed, but I have high blood pressure, or my statins are causing me a lot of myalgia. Can you help me out? They can do that too. And
yeah, that was my next question. Are primary care or internists doing it? Like, ooh,
Yeah, they are. Actually.
they are. Interesting.
Yeah, it's
Because medicine really can freak people out if they have a bad reaction.
Yeah.
They don't want to try it again or so. This is amazing.
Yeah, I give Dr. Tan and myself some credit, at least in Springfield, because we've been such early adopters and promoters of it for 10 to 12 years now, that a lot of our colleagues, when we practiced at Mercy, a lot of those primary care doctors have utilized that. We've got hospital programs now that are utilizing it. And again, it's a tool. It's one piece of the puzzle, but it can be significantly helpful in avoiding side effects and failures, treatment failures, and that type of thing. So I think, for moms that are listening, probably everybody can relate to breast cancer, and anybody that that's been treated or gone through that, they always check for the BRCA gene, right? Everybody knows that phrase. Why do they know that? Because you wouldn't dream of treating somebody with breast cancer without having that genetic test.
I had it.
Yeah,
Yes.
exactly.
Mm-hmm.
And I think Dr. Tan and I are at the point where we feel like, if at all possible, we want all of our patients to have this test, because it just makes us better doctors and allows us to treat families and kids more effectively.
Right.
in some hospital systems, they will put it in their EMR, and if you're prescribing in a way that's dangerous, it will flag it, and you can't go further until you pick something that is like in coordinates of something like a better choice.
Oh, really?
So an
wow.
EMR, for those who don't recognize
Yes.
the term, is electronic medical record.
Yes.
And so think of a physician prescribing something to which there's an allergy, and all of a sudden the computer flashes red, like, oh, Dr. John, don't you know they're allergic to this? I'm like, oh, gosh, yeah. So what Dr. Tan is talking about is that we're getting so good with this technology that eventually many electronic health records or electronic medical records, we believe will have the technology where you go to prescribe, let's say, a med people have heard of, maybe Prozac, and the information's in the EMR, and you get a flash that says, oh, you may want to decrease this by 20%, doctor, because this patient has this genetic change that they are not able to break down that med as quickly.
It's amazing.
Yeah, I mean, it really is the future of medicine. And Raymond's right. The Mayo Clinic is really at the forefront of this. And we've been blessed to kind of benefit from their knowledge and
so it's still progressing. It's still
yeah.
Okay. That's interesting.
I think this is, Miss Elizabeth, I think it's taken a lot of fear, because that's really a lot of the hesitation, maybe some of it when they're younger, it's, well, they're too young, but, a lot of it is just fear, and just listening to not just about being able to do these things, but just all the thought and everything. You're not just walking into a doctor that picks something off a list. There's a lot that goes into this field. And I think by parents listening to things like this, educating themselves and understanding that they're really going in, and you've put years and years, and those around you have put years into coming up with that recommendation. You didn't just read a book and pick the top,
Right.
In fact, it's even encouraged by pharmacy, PharmD. They may even tell you, why didn't you consider it?
Yeah. Yeah, so it's a kind of a team approach that a lot of health systems will have. They'll have a physician expert, they'll have a pharmacy expert on the team that looks at this technology and determines how do we include it in the way we care for our patients. And people in the region may or may not know this, but Dr. Tan is really our expert in the area. Nobody knows as much about pharmacogenomics as he does, and not just the psychiatric part. His wife's an internist, and I can't imagine that she's not benefited from his experience. But he's right. There's a lot of these issues in primary care where this technology could help. Something as simple as, I take a statin for high cholesterol. Thank you, Mom and Dad, right? And the test could potentially tell me, am I on the right one? Does my dose need to be adjusted? Or a reflux medication, for those that have gastroesophageal reflux disorder, or we all call it GERD, right? There are medications there that we could learn. Another common one is seizure disorders. A lot of kids with autism, there's a percentage that have seizures, and so a lot of those medications are included on a pharmacogenomic test like GeneSight. So there's multi-specialties that could benefit.
Geriatrics.
Yeah, geriatrics is great.
Yes.
Anybody listening that cares for a aging parent and takes them to the doctor, helps them manage their medications. Sometimes those lists are 10 or 12 or more long. So you think about, how do those drugs interfere with each other or interact with each other and the body, and so this would be a great technology, which is why I think not only the elderly, but the young children, especially if you're
nonverbal, like you mentioned earlier. Yeah. One of our mothers has a nonverbal, and I just think that would be so helpful.
Yeah. I did want to say something.
Sure.
And I cannot say that this happens for everyone, but we switched insurance companies halfway through the GeneSight process, and they wanted us to try 3 different medications before we went back on the. So one son was tested, and so they wanted him to try 3 different medications before they went back on this expensive drug. And we said we had the GeneSight test.
Okay.
And they actually said, oh, okay. So I don't know if that's going to happen for everyone, but that did happen for us. And we immediately got his expensive, I think it was Rexulti at the time, his expensive medication covered because of I don't remember which it was. Don't quote me on that.
Right.
But it
interesting,
got
though.
covered on the insurance.
Well, and having to try those 3 medications that possibly would not have worked for him,
Yeah.
that could have caused
you're
more
gonna-
trauma.
Yes,
Nightmare.
and you're taking him off of something that he's had for a long period of time, and then trying something that may have been in the red category. So
The irony of this is I expect there will be a day where insurance companies will say, no, we won't approve that medicine if you haven't had a pharmacogenomic test.
Yeah.
Because we don't want our patient that we're responsible for to fail, to have side effects that land them in the ER or hospital.
Which costs more money.
Which costs more money, exactly. I think at some point the research will be so rich that the insurance agents, insurers will, turn around and say, we really expect you to have this. I think the FDA having these, FDA warnings on medication labels, well, if I'm responsible for knowing this, how do I know it if I don't do the test? But if the insurance won't cover the test, then, that can be a challenge. But hopefully.
Yes, absolutely.
There is some inequality on that because in oncology, in order to prescribe some of the onco meds, you have to do these type of tests, otherwise they're not get approved. But in other fields, it's almost like you need to fail this before we'll decide that. So I'm not sure why they put that emphasis in one field, but then the other, you'll be fine, just fail a couple of them, and that's not fair.
Yeah, just try it and see what happens type
And
thing.
in psychiatry, mental health, we've done that for years, trial and error. Not that you couldn't whittle it down. There's other questions. You think about side effects of meds. You think about family history. Has anybody in the family had a good response to a medication in this group? So that's helpful to know. Is the patient heavy and we want to avoid further weight gain, or just the opposite? Are they thin and we don't want them to lose any more weight? Nobody really wants to be tired. So thinking about meds that may be sedating. So we think about side effects, we think about family history. It is frustrating when you have a medicine that's working and then an insurance company says, oh, well, with us, you have to fail these 3 other before. I'm like, that just makes no sense.
No, it
that's
doesn't.
a totally financially driven decision, and it's just terrible for the family and the patient, especially, to stop something that has been working well because there may be a cheaper option that either you have good reason not to try it.
That's insurance practicing medicine.
Well,
Yeah,
it is,
it's true.
and it's not that the new expensive drugs are always better. Sometimes they are. Sometimes they've improved something that really makes it a better choice. But it's pretty much financially driven most of the time.
So if my son goes to a primary or his internist and they want to start him on medication, well, first I'd probably start here at the ARC, but I could request that. I could say, can I please do the gene site testing first before he starts his medication?
If they have if they have access to pharmacogenomic testing, and if they don't, then you could
Hopefully
say,
I can pronounce that.
well, you could say genetic.
Okay.
Or just say PGX.
Yeah, PGX is the short. I'll give you, and I'm again not plugging this company, although I think they're probably good, but locally here in Springfield, Dynamic DNA, which is a genetic group, they offer pharmacogenomic testing. There are other companies outside of GeneSight. While Dr. Tan and I are, again, big fans of GeneSight, there's other tests out there. And as Dr. Tan alluded to, there's different levels of evidence in the research for all these different tests. And so, we, and by we, I mean Dr. Tan, when he does the research and then he sends it to me to say, look what I found, Kyle, he's really looking at the result of those studies there's about 3 or 4 groups in the world that do this research. And then they kind of put it together, and different companies then say, well, this this research with Farm GKB came, which is that the Dutch group?
No, that's like a database, but the guideline ones are CPEC and Dutch Pharmacogenomic Group.
So maybe they've done some studies that says this is a level 1 evidence-based, genetic interaction. We want to include it in the test. And so your good companies then will, respond to that and adjust their test and go, oh, now we're going to include this particular gene in our panel that we test for. So not all the tests are the same.
And they have had more oversight too. FDA's been watching it a lot closer. There's groups of the pathology that have been, it's called like the AMP group. It's not just the CAP or the CLIA. They have done that on purpose. They want more standardization. They want people to believe that the standardization will be like equal, not different.
Well, it's interesting. I mean, as a parent, I think that we talk about a lot of different things we worry about with our kids with autism after we're gone. And I will say that is, well, many things can keep me up at night about worrying about our son. But I did worry about that. Like, what happens if he's 50 and they give him some medicine and no one's around and he's having these terrible side effects? I mean, I think I agree, right? Our minds wander about. And so, like, this actually gives me a little peace of mind.
Yeah. And
this gene site, like, that would give me, it does give me peace of mind thinking, oh, but this, okay.
And it doesn't guarantee that a person won't ever have a side effect, right? We all, that can happen, but it certainly gives the information to the prescriber that, oh, I need to go higher, I need to go lower, or I need to avoid this medicine altogether.
Right.
And that's great. That's one less failure, one less side effect.
Right.
Did the results of the gene test, do they need to be repeated if he's had it like 11 years ago and he's gained weight?
It's a great question. Raymond, why don't you take that one?
Not necessarily, unless there's something on the gene panel that you want to use that would give, like that wants to identify something different than before. Because every now and then they will add candidate genes, and sometimes it can be relevant to see if it impacted the way that you use that medication, but not in every case.
Okay.
Yeah, and so when Dr. Tan and I look at the GeneSight website for our patient reports, we'll see reports from kids that we tested 10 years ago, and there'll be a little like upgrade button, and I believe it's at no cost. We can re-swab the patient at no cost to the family if they had a cost to begin with. And send that in. They can't do it they don't store the DNA that long, but we can re-swab at no cost, send it in, and then anything that's changed in that test since it was done can be upgraded. So they add medications, or sometimes they add new genes that have been discovered that have that high level of evidence. Sometimes they take them off. So we've experienced both of those in our years of using the test.
Okay.
Or take them off or change it or whatever. Okay. Yeah. Well, that's interesting. There's a couple questions here a couple of the parents that aren't here. It says, what suggestions do you have for an adult with autism or their caregiver when working with adult psychiatry? I think I don't know if that's medication related, but I guess it does if they...
Yeah, it's...
Or when do they go from like adult to like pediatric to adult psychiatry, and does that change the medication?
You're opening up a whole can of worms.
Okay.
Well, because some of our, they've seen you for years.
That was my question.
They've seen you for years, and then at what age do they age out to?
Yeah.
Right. So
and then does the adult, this is what my concern would be, the adult psychiatrist, because my child got autism, do they know very much about autism and the treatments and the medications to follow through to adulthood?
Yeah. So a lot of the disorders that present in childhood, like ADHD and autism, they can often make adult prescribers, whether that's a psychiatrist or a family physician, internist, whatever, they can make them nervous. They don't feel like they're the expert. Well, who's the expert? Those child guys, those pediatric providers, right? And so at some point, and often that's somewhere between age 18 and 21, most pediatricians and child psychiatrists will say, okay, it's time to transition you to adulthood, to an adult provider. But with folks on the spectrum, they may be chronologically 21 or 22 or 30, but be developmentally, they're still 10, 12, whatever. And so who knows that age range better? So you will find child psychiatrists more often treating those patients even into adulthood. I saw a patient in her 50s this week. I don't have a lot of them, but I have some. we're blessed here at the ARC to have Dr. Paul Dobard, and he works with a nurse practitioner as well that really target our older patients that are that we care for in our group homes and our ISLs. And but you'll find a lot of general adult psychiatrists and providers that are uncomfortable, that won't accept them. They won't accept the patient and say, no, I don't do that. I think there may be a sweet spot in finding a group like ours here at the ARC, where we have adult and child, and we have nurse practitioners that often will do the whole age span, whereas the psychiatrists, sometimes we specialize, and I just do kids and I just do adults. Nurse practitioners, they tend to be a little more flexible than us, and they sometimes will treat the whole spectrum, age spectrum, that is. So sometimes I think that's a really good fit, where you've got both adult and child psychiatry and nurse practitioners that feel comfortable. And so we see a lot of our patients maybe in their early 20s and 30s that are still working with a child psychiatrist like Dr. Tan or myself, but working with our nurse practitioner or with us directly. But yeah, it is a dilemma, not just with psychiatric care, but you guys, you moms know, with medical care as well.
Yes.
Finding a medical care provider, a general practitioner that's comfortable. These patients with neurodevelopmental disabilities, whether it's intellectual or autism, whatever, they sometimes take more time. They may be nonverbal. They may not be able to participate in their care. And, face it, medicine is a volume business. And I need to see 30 patients a day. And in our world, we may see 10 or 12 patients a day because we cannot go that fast. And so I would encourage you to, and probably the website and families talk, moms talk about, have you found a good provider, and utilize that, because there are all-stars out there. There are primary care all-stars that, that are just are willing to take more time, listen, and not be so rushed, and may be a better fit. In fact, finding medical care is so difficult that one of our I'll call it medium range goals, through our partnership with Jordan Valley, is to actually have a family nurse practitioner here in our autism center, Monday to Friday, 8 to 5, or we'll start out and add days, so that when we have patients on the spectrum that have a behavioral change, which may be due to an ear infection or a strep throat or a GI issue or whatever, instead of going to the emergency room, which is the worst, or even struggling to get them into their primary care provider, where we offer more of a I won't call it urgent care or walk-in, but where we offer, hey, yeah, we have somebody that can see your loved one. They're not going to have 40 people on their schedule that day. You can come into a building that was especially built for folks on the spectrum, full of people, expert in treating people on the spectrum, and get your care. So we have a couple of exam rooms that are very sparse. We can lower the lights. They have a lot of sound deafening, like in the room we're in right now. And we have looks like a Chase lounge that can flatten into a bed automatically if we need it, but otherwise it's just kind of calm, cool.
Would be great.
Yeah, it really would, because we hear that a lot, and it's not just for ARC patients, but there's a lot of organizations out there that are working with people on the spectrum, have some kind of neurodevelopmental disability, and they need to go see the doctor, and they take their patient, their family member in, and maybe they make a noise, or they slam the table, or they're pacing or whatever, and they get invited to leave, which is embarrassing to my profession, I would argue, and a shame. And parents hear things like, bring them back when they're under control. And the reply would be, well, they are under control. This is their baseline behavior. Right. Well, we can't have that in our office. And I'm like, are you kidding me? How pretentious is that, right? I mean, so hopefully offering an opportunity for some patients that may be in that gray area where, I can't get into my provider, or I really don't want to go to the emergency room, but they've had a behavioral change. I don't know if it's strep throat
And they could have been sick for a while.
Exactly. And then we'll have a nurse practitioner that is especially gifted at working with that population here, and be able to offer that. So I hope in the next year, we're partnering with Jordan Valley, one of our partners, to see if we can identify the right provider. One of our own nurse practitioners, Karina Guffey, is dual certified in family med or peds, one of the two, and psychiatry. So
Wow.
she's going to do a couple of half days.
And she's bilingual.
I didn't know that.
Yeah. Oh, she's a gem. Yeah. So, but yeah, that's one of our future goals here at the ARC is to be able to provide that. So if NOVA or some other organization that's working with folks, our neighbors across the street, Empower Abilities, if they identify something like, y'all, nothing else has changed. The meds haven't changed, but all of a sudden their behavior has changed. I wonder if,
It's true.
let's call the ARC and see if we could get them in and work with a provider, not taking over their primary care, not stealing a patient from
Right.
anybody, but just like, we can.
Well, some corporations are doing that. They're providing
Yeah.
urgent care or, a nurse or doctor in their facilities
Well, and just
to be convenient for their employees.
by working with other providers, other pediatricians, you're educating them.
Yes, absolutely.
True.
Absolutely.
True.
In fact, one of the grants that the ARC is seeking currently is some state funding to go into hospitals, ERs, urgent cares, and train the staff. If you get a patient that comes in with autism or another neurodevelopmental disability, what do you need to do differently to treat them? What might help that experience go better for both you and the patient?
Right.
So that's going to be money well spent. If you've ever taken your loved one on the spectrum to an ER, they're loud, they're busy, they don't have any experts really that are there. You'll wait forever, which is not good. And so trying to avoid that as often as possible.
Yeah, it is. I mean, we've talked about that on other podcasts, how most of our kids are higher functioning, and I can't even imagine what that's like for, lower, for lack of a better term, lower functioning ones. But yeah, it's rough.
Yeah.
So,
Well, and to have these services under one roof,
Mhm.
and you guys
great.
can all coordinate together and partner together for our children.
That's awesome.
Speaking of services, not under this roof, but I think exciting new technology and
Yeah, I was just
development.
going to ask you about that.
Yeah, I want-
Promising medicines or treatments
Yeah,
on the horizon.
I want Dr. Tan to start about, it's technically not under this roof because we're out of space, but across the street, if you will.
You just opened.
Yeah, I know, isn't that sad?
I know.
We just opened and we are out of space, but we backfilled when we brought on what many of you will recognize as TheraCare. That group became part of the ARC recently, and they're retiring the TheraCare name. And so many people listening to this podcast may go, oh yeah, I took my kid there for PT or speech. That building is now our behavioral health building where Dr. Tan and Dr. Dobard and some of our nurse
Okay.
practitioners see patient. And so Raymund has got some exciting technological offerings in the works. And so I want to be quiet for a minute here and let
You
him.
want to touch on that, Dr. Tan?
Absolutely.
Just briefly, but I just wanted to say.
Or is that another podcast where we need to go through it?
I'll just briefly explain, like a direction of where psychiatry is going and how we can apply it to autistic spectrum.
Okay.
Meds, they can play a role, therapy, but I want you to also remember how neuromodulation can change how we feel, act, think, and it is here at the ARC.
Can you explain neuromodulation?
Yes.
It's like
Please.
brain stimulation, and it can be in different forms of energy or ways, but the one that we have at the ARC and soon to use is through magnetic pulses. And it induces neuroplasticity, but it's with precision. And when I say precision, it has a certain like ways of identifying biomarker, biosignature, like waves in the brain, and being able to identify if that part of the brain has a lack of connectivity or a lack of synchronization. But the thing is, not only being able to identify it, can you modify it or modulate it and entrain it in a way that will improve gain of function. That is the magic of it. To say from someone who is extremely emotional or couldn't multitask or couldn't speak very well, and then all of a sudden you could see Johnny, tell him what you think. And he starts to speak his mind. And I am not joking.
Really?
That is, yeah.
So
At what length of time? I mean, like how many therapies or what is it?
It may take some, maybe 6 to 8 weeks. Severity does impact at your age, but even if that's the case, there are times that even with that kind of like level 3, it still does amazing things.
Really?
So I want to go back to a couple of things that Dr. Tan said, just for those that aren't as techie. So the magnetic waves that we use, a technology called transcranial magnetic stimulation, or TMS. So if you Google TMS, you're going to see different kinds of machines that are used. Think of sitting in a dental chair. And you know when they take your x-rays and they bring that machine right up to your cheek and they're taking so it kind of looks like that, although there's different ways of delivering that magnetic energy to a specific part of the brain. Now, how do you know what part of the brain? Well, one of the very cutting edge technologies that Raymund is leading here at the ARC uses an EEG, which many moms and dads will recognize is when kids have seizures, we do an EEG. Think of putting that little cap on with all those little electrodes and identifying abnormal waves. And by that, I mean not like seizure waves, which are abnormal, but instead of having a well-organized pattern in the brain, we look specifically for an abnormality in a particular area. And so we can look for that and then come up with a plan specific to that patient to try and change that brainwave pattern to a healthier one, for lack of a better word. We use words like more organized, but a healthier. And the research would suggest that there are folks on the spectrum that get better verbal skills. So Dr. Tan alluded to kids that have been nonverbal that then are able to express themselves. And that's dramatic and exciting. Yes, exactly. And maybe folks that had more difficulties with behaviors that softens from the particular treatment. So we've invested, thanks to our leaders here at the ARC, we've invested in 2 different TMS machines that provide that magnetic stimulation in a variety of ways. There's a typical one. There's one called Deep TMS. There's another one called MERT, MERT, and that's the kind of cutting edge one. Dr. Tan will be the first provider in the state of Missouri to offer this treatment, which is, while not yet FDA approved, well on the way from some of the academic studies, targeting specifically people on the autism spectrum. So starts with an EEG to identify the abnormalities in the brain, and then a targeted focus. And typically that's a daily treatment, Raymund, for like Monday through Friday. Right. For 6 weeks would be a typical course. It doesn't mean that like you're done then. You may continue, or you may continue at some pace. The treatments could last, what's the typical duration, Raymund, that you might do for a TMS session?
About like 30 minutes, 40 minutes. And every 2 weeks they reassess the acute EEG, quantitative EEG. And it's slightly, once they do the EEG and then they convert it to the quantitative, they will look for like a certain peak wave, or if it's underdeveloped, but it's the alpha. So sometimes they call it alpha guided. Not saying that the other waves like beta or delta, if they are not important, but if you have the synchronization and a dominant peak of the alpha from the posterior, central, and frontal, then there's a lot of optimization of the default mode center, and the brain is like communicating very efficiently. When you don't, then sometimes like the function isn't as optimal as it should be.
You have optimal alpha waves when you're sitting quietly with your eyes closed, not sleeping, but awake, but in that restful pace. And that's really what we're trying to optimize when we use the MERT TMS program. There's other technologies that Dr. Tan has been using for years. So one example is Alpha Stim, which utilizes a different electrical impulse to try and, again, train that alpha wave to be more organized, more synchronous. So he's really been doing this for years, but we think it's going to be a significant new treatment option for.
So parents talk about, and they say they've noticed a change. My child's.
Oh, they will have them to show their improvement. Sometimes they'll ask them to speak or talk, and they will show a before and after video. But sometimes it's so dramatic that it is just hard to like believe that.
Right.
Wow, how did this ever happen? What did you do? But the proof is the gain of function can do things that you're not. A lot of times they don't wear headsets anymore. A lot of times how you can tell if it's working is when they would like avoid crowds or get over emotional, but now they're enjoying things in Disneyland like that. And then the pronunciation is like very clear what they want to say.
Dr. Tan showed me a video recently, and it was really cute because it was started out with the mom talking about all the things that she had tried for her child with autism. And as you moms know, you'll go to no end.
Yep.
And then she came across this new TMS program, the MERT program, and so she was really excited. And then they cut to the dad, and the dad said, "Yeah, listen, I assumed it was going to be one more thing that didn't really help, right?" And then he talked about the changes that he eventually saw, and the neighbor down the street saw, and at the end of that video clip, the mom comes back to say, if I remember it correctly, we had done ABA, we had done all these other things. I wish we had started with this because it's been the most dramatic. So we're excited to bring it. It's going to take us a while we've all been trained. We've passed our tests. We have the machines set up, and we're just in the process of getting everything set so that we can begin offering that to the community. And there's a lot of work that's gone into it, but I think someday down the road it will be significant. I mean, it'll be synonymous with treatment of autism, and in this part of the region, it's going to be because of Dr. Tan, because he's had this dream and this
I've heard
desire.
about it for many years.
Yeah. Yeah. So,
and I have waited for it, and I was so excited. Every time I see Dr. Tan, he talks about it, and we do have an Alpha Stem. So we've used Alpha Stem, and now our son is on the list for this.
Oh, wow.
So the list.
The MERT is also synonymous also with PTSD and the VA.
Yeah, that's what I was going to point out too, real quickly. TMS, the technology, whether it's MERT or the deep TMS, or there's another one called Theta Burst, which is a very short, like 3-minute treatment. Those are FDA approved to treat a variety of things like depression, anxious depression, OCD. There's smoking cessation. There are a number of things that are, quote, FDA approved, and then there's as many or more that are in the research stage. A lot of this technology has come through the military, treating veterans with PTSD, and so we're excited because the local VA doesn't offer this. Our veterans have to go to Columbia to get TMS treatment, and so we're excited at some point to hopefully be able to open the door to offer that as well to those folks. But it's an exciting, and Raymund started out with that phrase, neuromodulation. It really is, we believe, to be one of the biggest changes coming to the treatment of mental health issues. A lot of people have heard of electroconvulsive shock therapy, or ECT, which is a very intrusive, it's a terrific therapy for some very small segment of the population that we treat, but it requires a general anesthesia, and it's got lots of side effects. And so, but it's going to be viewed someday, I think, as the predecessor to all neuromodulation, because it was neuromodulation. Everybody says, well, how does ECT work? We don't know. It's like flipping the on-off button on your computer. But it clearly is through electricity, because that's exactly what they're doing, shocking the brain to the point that you have a seizure. Now we're much more precise. We don't have to use that much electricity. We can use a magnetic generated energy in a specific place in the brain to induce, as if not better. There are lots of studies showing that TMS is almost, if not better than ECT, which would have been considered the gold standard in psychiatry for some disorders. So,
and our TMS, some have asked me, will it ever get approval in children, adolescents? And the answer is already yes.
Wow.
Yeah, because I remember
of you guys,
Yeah.
because of you guys doing the work and
Pushing
believing,
for it.
pushing for it,
Yeah.
and doing your own work and your studies to make it
Yeah.
happen.
Thank
I
you.
remember.
Thank you.
I
Goodness
remember
gracious.
you have been talking about it for years, and I'm like, okay, my kids are almost 18. It's like they can finally get it at this point. And I mean, because I have all my kids have some sort of genetic. One has autism, but I have two other ones with major depression and anxiety, and you've talked about that for the one with depression as well. Is that going to be the same if you're treating for autism or depression? Is it the same 6 weeks, 30 minutes, or is it like, is there a difference?
6 weeks, 8 weeks, but it really depends on the brain signature and how it's reorganized. So every 2 weeks when you do it, are you trending more towards the dominant alpha that is where it shows synchrony in all three different locations, the posterior, front, middle, and back. If it's already trending to look like an ideal dominant alpha peak, then you may not need to go further like that. But it depends on the individual. That's why sometimes it might be only 4 weeks you might need. Might need 6, but others might be as much as 8 or more.
Does insurance cover this?
Oh, it's a great question. So
It's always the question.
Yeah, most insurances, require a prior authorization. So, for example, TMS for depression, they're going to want to see a failed trials of 3 to 4 medications, and not just like he took it for 2 days, but a therapeutic dose for enough time that you can document that it was a therapeutic failure and not just a lack of enough medicine.
A lot of data to show.
Exactly. So there will be some hoops to jump through, and just like many of the medicines that we use may be off-label, TMS may be off-label for a number of disorders that are still very promising. So some families will choose to pay out of pocket for that. It's funny because I have a meeting next week here at the ARC to talk about how are we going to do that. We provide for all of our therapies. We have insurance, we have Medicaid, we have some people are paying out of pocket. We have sliding scale fees that we use. We're getting our house in order, so to speak, so that we're able to answer those questions from families. But it's such a new technology to us. I mean, Dr. Tan and I this week did our training on one of our new machines on Tuesday. So it's that fresh. And but we're really excited to bring it to the community. And I think, as Raymund alluded to, there are going to be some families that are have significant improvements.
It's life-changing.
Yeah, and there will be families that we try it, and it won't be just like we do with the medicine, where it's like, well, we're hopeful. But the nice thing about it is that it's not intrusive, invasive like ECT, and you could make a strong argument that it has less side effects and risks than a medication.
Wow, that's exciting.
Very.
Well, before we wrap it up on medication, do other moms have any other questions for Dr. John or Dr. Tan?
I think, as we all know, a lot of us, when is it time? When is it time, to go ahead and go and decide medication?
Yeah. I have a quick answer to that. When the impairment is preventing your child or family member from being successful. So ADHD, attention deficit hyperactivity disorder, is a neurodevelopmental disorder. It's one of the most basic things that we treat, and pediatricians, family physicians treat. And some parents will say, I don't want to use medications. And I'll say, that's great, but you'll probably come to some point where the impairment of your child is impacting their ability to be successful. And that, to me, is often when you want to institute medicine. Now, ADHD might have been a bad choice because it's one of only 3 disorders that I can think of that's really a med-first approach. You could argue that bipolar disorder, schizophrenia, and ADHD, while therapy can help all those, it doesn't change brain chemistry and those 3, but depression, anxiety, lots of other things, therapy first, and then when it's severe enough, medication. So I think parents, I don't think you should feel bad about not wanting to use medication, but you also shouldn't be an ostrich with your head in the sand, as your child's getting kicked out of programs and failing different things because all in an attempt to say, well, my kid doesn't need meds, but maybe your kid would thrive with the right
you're
medication.
exactly right.
And I think a
You're
lot of the
exactly right.
kids, I've heard stories that they've even realized a huge difference. Once they start the meds, they start seeing things differently.
Yeah, they feel
Absolutely.
better.
Mm-hmm.
Yeah.
That's definitely happened in my household.
In some of the studies, if you need to use medication along with therapy, will improve the outcome greater than one or the other.
Right.
Yeah.
That's awesome.
Okay.
But yeah, I was just going to close with that I tell parents, I knew when it was time because I, waited and waited, been working with Dr. Tan. But then when I realized my son could not focus long enough to even walk down the stairs, I'm like, what else is he missing? Every time we get in the car, it takes so long because he's so distracted and focused on other things than just walking down the stairs. Yeah. And just giving him just a small dose changed our lives dramatically. And it just back up what you say that, when it starts to impact them, at some point you just get that moment where you're like, it's time.
Right.
I would like to leave a little advice for parents when it's that time. So you want to make sure you're working with a provider that you feel comfortable with, that listens to you, and that's available to you. There are providers in our region that don't fulfill those criteria.
Right.
You see a different provider every time. You don't get your phone calls answered. You can't ask a question. Those are all signs that should make the hairs on your neck go,
You're
I'm not
exactly
in the
right,
right
Dr.
place.
John.
You want a provider that you feel comfortable with, that will listen to you, number one, that'll answer your questions thoroughly about benefits and side effects and that type of thing. And you can't do that in 30 seconds, folks. You need somebody that is in the room with you long enough, who's done a thorough assessment, that hopefully has included the pharmacogenomic PGX testing because we think it's helpful. But just I would encourage folks that if that's not your provider, then don't start medicines there because it's likely that you're not going to have a good experience.
Right. Thank you so much, Dr. John and Dr. Tan. Dr. Lindsey had to step out. Thank you so much for being here with us. Hopefully you'll be back
Absolutely.
on our podcast as guests. So we're going to wrap it up, and we're going to say something?
This has been wonderful.
It has been wonderful.
Yes, thank
It
you
has
so
been.
much.
Thanks for inviting us.
Oh, thank
very
you
much.
so much again. Okay, Tara, where can everybody find us?
Okay.
Are you ready?
I'm ready. I wrote it down. Okay, you can listen to us on Apple and Spotify under Navigating Adult Autism. You could also listen to us on our website at navigatingadultautism.com. We also are on Facebook and Instagram under Navigating Adult Autism Podcast, and you can contact us at moms@navigatingadultautism.com, or you can message us on Facebook, and I might reply to you a little bit quicker on Facebook because I don't look at this email address very often.
Yeah, well, that's okay. Once again, this was the Arc of the Ozarks Autism and Neurodevelopmental Center, Dr. Tan and Dr. John and Dr. Lindsey. Thank you again.
Thank you.
Bye.
See you next
Bye-bye.
week.
Bye-bye.